Thanks everybody for joining us. I'm here to host Nigel Davies for a talk for NASGP on ophthalmology and general practice. Nigel's going to do a quick presentation and then we'll save a bit of time afterwards for a Q&A. But otherwise, I think that's all you need to know. So Nigel, over to you.
Thank you very much, and thank you everybody for joining. So as Elliot said, I'm an ophthalmologist. I work at St Thomas's Hospital, I've done ophthalmology since about 1992 or thereabouts, so a reasonable amount of time. And one of the things I'm very aware of is that when people come to the eye clinic, we've got all the gear and all the gizmos to allow us to investigate eyes in great detail. And also ophthalmology has changed enormously in the last 20 years or so. So what I wanted to do was just to run through some things that I would think would be helpful for you as practicing GPs about how to approach a patient when they present to you with an eye problem. I know that a lot of patients go to their optometrists, who then might ask you to refer the patient on, but quite a proportion will come to you when they notice something going on with their eye, particularly the acute things. And when you deal with something that's not so often that you have to, and also it's difficult to examine because it's so tiddly, it can be slightly out of comfort zone. So on the whole, just like with all of our things, if we want to have a sensible way to start the care for somebody who presents with our fairly short period of time that we have, and also we've got many other pressures as well during the day, I think it's quite good to have a nice structure to use to approach things. So I'm just going to share the slides, which I think means that I disappear for a little bit. Please feel free to ask any questions that crop up during the time that I'm talking, because I'm very happy to answer them. And if you try to save them till the end, you might forget, or the subject might have drifted on, things like that. So please feel free to interrupt and ask anything that comes to mind. So I've just called it a little bit of ophthalmology. And let's see if the thing moves forwards. Oh yeah, there we go. So this is the problem that you have, is that if I wanted to, I could go through lots of different diagnoses, lots of different things and tell you how to treat them. But that's not really terribly helpful, because people don't present with the diagnosis, do they? They give you things like this, bits from the newspaper, and they've got different symptoms, and they'll tell you about something that happened with their knee that somehow is connected to their eye. And what you've got to do with your skills is to sift through all of those things to get to the root of the problem. So I'm going to try to adopt a way of approaching things through the symptoms and the signs, not so much through each different individual diagnosis, if that makes sense. And there are two things that I think that you can use broadly. One is very general, and you'll be using it already, but maybe not so much in a formalized way. And two structures. The first structure is a general one for all of medicine, really. The second one is just a nice way to think about how to approach a patient with an eye problem. As I say, please answer some questions. Once I've done those two structures, I'll go through some examples of things and show you some pictures, and we can have a look at those as well. So the first one is just to ask this question, which is simply this, is what's going to be wrong with the next patient you see? What's going to be wrong with the first patient you see this afternoon? And if I ask you that, then I think there's only one answer really, and that is, I don't know, because you don't know. But if I change one word, the question becomes very different. And that is, what is likely to be wrong with the next patient that you see? Because that's a very different question, isn't it? And of course, I think you can potentially have a thought about what might be likely to be wrong with somebody, because we know we've got an idea of the various likelihoods of different problems cropping up based on what things are common in, just in the general population and in the specific population that we look after. And we've read about them in books, and we've spoken to our colleagues, and we know that this condition presents more commonly than that. And I've put this picture in just to show you that books have more than one use. Where's my pointer gone? I think you can see the point of it. So this is a patient who actually had a bad muscular dystrophy. You can see he can't elevate his upper limb there. And he couldn't reach his chin onto the chin rest of the slit lamp. So, but he said, you can't lift me because I've got no muscle tone. He said, but have you got any books? Because if you've got some books, I'll drive my wheelchair up onto the books, and then I'll be able to reach my chin onto the chin rest. So I went to the cupboard, and these are the 4 volumes of Albert and Jacobi X Principles and Practice of Ophthalmology. There we are. It's just a nice alternative use of books that sometimes don't get read. But I love the big books because I just find that it's fascinating to put everything together and fill in that jigsaw puzzle of how things work. And so I just thought a nice example of an alternative use of books for you. So we have, when we are thinking that we're going to see a patient, we have some prior knowledge. And the prior knowledge comes from our experience and the instance of problems, etc., as I said. So you've got a mental map of the likelihood of different problems. And then what we do is we collect some information about the patient, and our ideas about what might be wrong will certainly change. And that's what we do with every patient that we see. And you may have heard of Thomas Bayes and Bayesian analysis, but this is the scientific basis for how all of that works is called Bayesian analysis. He was a Presbyterian church minister who died in 1761. And amongst his writings was found an essay about the doctrine of the treatment of chances. And that is all about treating probability as a partial belief. And his equation is used in many different situations. And we use it ourselves, not in a quantitative way, but just in the way that allows us to sift through the different diagnostic possibilities when we're taking a history and doing an examination. And so what we have before we start is a before test probability or an a priori probability, and then we do a test and we get the result of the test, which is either positive or negative or whatever value we get. That includes asking all questions and things or examining the patient, and that changes our mind about what might be happening. And then we get the a posteriori probability or the after test probability. And the whole aim of making the diagnosis is to go through a series of different questions or examination bits or other investigations to reduce the vast number of different possible differential diagnoses to a very small list. And so the test, if you define a test in that way, it's any gathering of information about a patient. It's about their age, the gender, their body habitus. Just seeing their name might be enough, because they can instantly change your idea about what might be wrong. And here's the scary line: I can use this to play with your thoughts. And so I'm going to ask you this question. So the patient, it says the patient's got unilateral loss of vision. And if you think for a moment about unilateral loss of vision, there's quite a large number of causes of that. But then you find out that your patient's name is Ethel. So I put into Google Ethel, and here's a picture of an Ethel. And I think you're already there, knowing that patient's name is that tends to mean a Caucasian elderly lady. So I don't want to put people on the spot, but if anyone has a burning idea about what a unilateral loss of vision in an elderly Caucasian lady might be caused by, feel free to just pipe up if you wish. Give you a couple of seconds. Anyone want to say? Oh, there's something in the chat, I think. Let's have a look to see. Yeah, it could be. Posterior circulation is likely to cause bilateral because, of course, the cortex, this is posterior circulation stroke, that would affect the hemifield, the homonymous hemifield, or it would give you a hemifield loss more than a unilateral loss of vision. Retinal detachment might be the case. Other things with this sort of lady, it's much more likely to be a problem like a central retinal vein occlusion. That can happen, a central retinal artery occlusion, or an ischemic optic neuropathy. And if it's an ischemic optic neuropathy, it can be either the very serious one, which in this age group is more likely, is giant cell arteritis and arteritic anterior ischemic optic neuropathy, but the other one is the non-arteritic anterior optic neuropathy. So you principally tend to think of vascular causes, or it could be a branch vein occlusion or a branch artery occlusion. So that's what the elderly person is most likely to get, something like that. And that is a reasonably small list out of the potential differential diagnoses. So let's have a look at our next patient. And our next patient also has unilateral loss of vision. But the next patient is called, oh, I've lost my point, I think. Next patient is called Luke. And here's a Luke from Google. When I put in Luke, of course, you get Luke Skywalker in the main and many other things, and then some famous Luke. So I just chose somebody who, this is from a website called Pixabay, where these pictures are free for commercial use, it says. So this is a person called Luke. And of course, when you hear the name Luke, it does tend to mean a youngish man, doesn't it? So any suggestions about what a person called Luke or a young male might have with unilateral loss of vision? Yes, optic neuritis, absolutely right. That would be the first one. With painless loss of vision, optic neuritis would definitely be true. Retinal detachment would also be another one. I mean, he doesn't look particularly myopic, but it's just an example of the sort of person who would carry that name. So it's really amazing how much information we get from the patient, even just from their name, their surname, and things like that. So at St Thomas's in Southeast London, we have a very big Afro-Caribbean population. So we can see the patient's name, we can often know the ethnicity, and that will help guide us as to what problem the person might have. And that's just a classic example of how our mind works with Bayesian analysis. And then you go collecting more and more information about the patient. So when I was a younger, still a registrar at Moorfields, my boss used to call me Tintin because I had a bit more hair then, and he thought I had this little quiff at the front. So he used to say, keep using those grey cells, Tintin. And the question is to ask is how much of this fairly soft information do we need to gather before we get a really good idea about what the diagnosis is? And it's about 8 or 10 bits. So if you have a sensitivity or specificity of about 70% for each test or question that you ask, a single one is not going to change things very much. But when you've got 8 or 9 or 10 in a row, then actually you get your short list of a large number of differential diagnoses down to about 3. And that's what William Osler said, in essence. Listen to the patient. They are telling you the diagnosis. And on the whole, certainly with ophthalmology, that is a really useful thing. And often each step you should be thinking, well, what's this person telling me? And then what am I looking for to confirm things with various bits of the examination? And I'm sure you do that for your patients with cardiac problems or respiratory problems, is you're guided and know what to look for on the basis of your internal Bayesian analysis of the information you have to date. So that's the first general thing. The second one is it's very important to have a good structure for the examination for the eyes. And I know, when we're at medical school, we're taught, if we're going to do the cardiovascular examination, the first thing we start off with is picking up the patient's right hand and looking at their hands and looking for clubbing and looking at the palmar erythema and all those other things that you'll do much more frequently than I now. So we follow that structure through, and generally, I think there's only 2 things that you can actually do. And the first one is that you can examine the anatomy. So you look at the anatomy of the eye, and we look at it in vivo. We don't get histology of the eye, and we don't really see the anatomy of the rest of the brain either. So I grade those ones out. And most of the time, we are limited in our anatomical assessment of the visual system to just looking at the eye. And we're limited then to the technique that we use. And in general practice, of course, that usually often is your own naked eye, or with a magnifier, or with an ophthalmoscope, and not so much else. But actually, you can get a long way with doing that. The other thing, of course, if I've said anatomy, that comes to mind straight away is that you can assess the pointer thing's gone, hold on, is the function. And when you think about the way the visual system works, there's 2 sets of tests that we can actually do. One are the subjective tests, where the patient needs to give a response to a stimulus, that's like visual acuity or color vision or visual fields. And the other are the more objective tests, where the patient doesn't need to give a response. It doesn't really tell you what they perceive, because that's all internal, but it can give you an idea about the workings of the visual system to some extent. And that the only real clinical one for that is pupil reactions, We can do electrophysiology. That takes a whole morning to do for a patient, take a good few hours, and we use it for various things like inherited retinal dystrophies to divide up how the retina is working in different ways. But it's not really a broadly used clinical test even in ophthalmology. It's more of a sort of very specific one. So actually, in terms of assessing function, we just have the subjective tests and our objective tests of the pupil reactions. When it comes to pupil reactions, the one that is the most useful for you, I think, is the relative afferent pupillary defect. And I thought if about a way that I might be able to try to show you that on the Zoom link, but I don't think it would work terribly well. But learning how to do a good afferent pupillary test is very important. If I would say one thing about that, and that is that often when you're taught about that, particularly at medical school, you're taught to do the swinging flashlight test, which is fine, but you're taught to swing the light away from one eye and swing it into the other. And the issue with doing it like that at that sort of speed is that it only takes 150 milliseconds for the pupils to start to dilate. So what you really need to do is you need to illuminate one side and then very rapidly flip your pen torch to the other side. So in less than 0.15 of a second, ideally, and then watch the pupil on that side to see if it dilates. Then you can detect an afferent. So I would just be illuminate one eye, watch for the pupil constriction, snap it over to the other eye, pause for a second or two. If that pupil dilates, it's an afferent on that side. If it dilates when you go back the other way, it's an afferent on that side. I'm sorry, I can't really demonstrate that to you, but I found that quite a useful way of explaining it. Otherwise, you get yourself quite confused about things. When it comes to color, you can use the Ishihara color test plates, but actually the commonest thing that's affected with color is optic nerve disease, and the commonest color that's affected is deep red. So anything that looks deep red to the healthy eye would look desaturated and look rather pink to the diseased optic nerve eye. So you can easily find something which is a fairly saturated deep red to use as a color test. And with visual fields, again, there's multiple different ways of doing a confrontation visual field. They won't detect a what's it called? A subtle defect, but they'll detect a hemianopia for you quite easily if you do it carefully. So these are our usual tools, I think, that we have. We've got the acuity chart, we've got the near one. Do you use ophthalmoscopes? Funnily enough, I haven't used an ophthalmoscope for a very long time because I have other ways of looking at it deep inside the eye. It's a goodish tool if you practice with it, just like a stethoscope. You need to be au fait with how it works, and the signs in the eye are fairly subtle. And I wouldn't worry too much about using an ophthalmoscope because most of the time your history and examination will tell you something is going on that you need to get a bit of help for. And I've put fluorescein there because those are very helpful. You could hide the drops or those little strips. And that's really what we have. So fairly simple stuff. Does anyone have any questions about that fairly straightforward introduction? Those are the two structures that I use all the time to help me assess patients, and they can, on the whole, be applied to anything in medicine because, again, thinking about the cardiovascular system, you can separate it into things that are assessments of its function and things that are assessments of its anatomy. So I thought probably one of the most useful things for you would be just to talk about some patients with red eyes, because they're the most likely things that are going to come your way. And the differential diagnosis of red eyes this is not at all inclusive. I'm sure you've spotted many things that are missing from that list already, but these are some of the commoner ones. And you might think it's a bit odd for me to put things like artery occlusion in a red eye, but I explain why that is as time goes by. But let's have a look at a few cases, because that's quite where it becomes fun and it applies the Bayesian analysis. So this is somebody who had a cold recently and then got some discharge from their eye, and their vision is okay, and they come to see you about it. So that's 3 bits of information. So not enough to get a full diagnosis, but then you see the offending eye and it looks like this. Does anybody want to suggest what might be going on here? Can't see anything. Do I see the chat at the moment? Oh, there we go. Yeah, it's popped up. Yeah, it could certainly be a viral conjunctivitis. Absolutely, because they're most likely the most common type of conjunctivitis is with a virus. Adenovirus is awful. There are many other different types of virus that will affect the eye. But what you can see here is slightly swollen lids, a little bit of crusty discharge around the medial canthus, slightly swollen conjunctiva as well. So there is a seat of inflammation around there. And if you pull that lid down, you'll see the inside, the palpebral conjunctiva will give you some signs away. If it is a viral conjunctivitis, it could, of course, be a bacterial conjunctivitis. If it's a viral conjunctivitis, there's one other thing that you can do, which is very helpful in working out whether it's a virus or not. Does anyone know what that might be? It would be feeling for pre-auricular lymph nodes, because if you have a viral conjunctivitis, very often you'll get a tender pre-auricular lymph nodes, and they feel like a little pea just sitting there. So if that's on the affected side, that makes it much more likely that it's a viral conjunctivitis. Here are the things I thought it could be. So it could be blepharitis, yeah, because I have that and it's very annoying and it flares up from time to time and will get worse if you have another hit on the immune system. Conjunctivitis, as we said, which could be viral or bacterial. It could just be a foreign body as well. And now I've got my video a bit in the wrong way. And then could it be microbial keratitis? Well, it could. They could have an infection in their cornea just beginning. It's less likely though. Or it could be a herpes keratitis. Yes, it could, because people get herpes virus flare-ups when their immune system is knocked down. And it could be, oh my goodness, how interesting, could be a orbital cellulitis. So orbital cellulitis is pretty serious, and actually quite remarkably, an anesthetic friend of mine today sent me a photograph of a friend of his. He said, my friend has had, I just realized this, I should have sent you that picture, but of course I don't have her lady's permission to use it. But it said, this is my friend who had a cold recently, and she's got this sore eye. What do you think? And she actually was looking straight at the camera with her good eye. No, other way, straight at the camera with the eye that looked like this, all swollen up, but her other eye was pointed right over to the side. And she clearly had orbital involvement because her eye movements were affected. So my advice was she needs to go to the main casualty locally straight away, because orbital cellulitis is potentially life-threatening. So if you're concerned about orbital cellulitis, check the eye movements. If the eye movements are full, even if the lids are really swollen up, then it's all preseptal. It doesn't get your eye movements until it goes behind the orbital septum. And it could be a chalazion as well, the meibomian cyst as well, because those can flare up. So those are the most common ones, like the most likely to be conjunctivitis. But you have to sort of sometimes let your mind think about these other things, particularly if it doesn't quite fit. Does that all make sense? Okay. So, oh, here's the story and the offending eye. Walking along a windy street, eye pain. This has happened to me, painful when blinking. What do you think? Yeah, foreign body, quite right. That would be the most likely thing. And then I'll just show you this because this is quite interesting. Here is a photograph of a, another, yeah, foreign body, of a patient. But look at the foreign body though. There's some fluorescein along here. You can see it's a tiny bit of clear plastic like that, which you can see quite clearly on this anterior segment photo. But naked eye, that's slightly harder to see. And it's come away from that bit, leaving that little abrasion there. So sometimes foreign bodies are dead easy to see. They're little dark things, and you can wipe them off with a cotton bud without any difficulty. But other times you can't find them so easily. And putting a drop of fluorescein in is very helpful, particularly when it comes to a subtarsal foreign body. So there, when you flip the lid over, you might see it, you just wipe it away with a cotton bud. But if it's a bit of sand and it's pale coloured, you won't see it very easily on the surface of the eyelid. So what you can do is that you put a drop of fluorescein in before you avert the lid, and that then sticks around the foreign body because it will get some mucus around it. And when you shine your blue light on, my goodness, it just lights up and it's very easy to see. And then you wipe that with the cotton bud and away it comes. And this is the best bit of ophthalmology of all, because the patient gives you a big hug for removing a subtarsal foreign body, because it's so painful and it's such instant relief. So if you're struggling with that and trying to find the subtarsal foreign body, two things. One is putting a drop of fluorescein in. But if you don't have a drop of fluorescein, when you've reverted the lid, just wipe it anyway with the cotton bud, because you may well remove whatever is there. What did I put on the other list of things? So yeah, foreign body is the most likely. With the foreign body on the front surface, you can get a microbial keratitis as well. So especially if it's been there for a few days, that should declare itself with a little white dot. I put herpes in here because when you've had an abrasion, and you will see, I'm sure you've seen loads of abrasions, as the edges come together, it forms a little line, and the little line can look quite like a herpetic ulcer. So if you've got the history of trauma and it looks like the patient has got herpes simplex, if there's just a straight little line without too many wiggly branches on it, it's probably just an abrasion that's healing, and you can give them some chloramphenicol and it will almost certainly get better with that. So just bear that in mind, particularly if somebody doesn't have a history of cold sores and things, because that's just one of the differential diagnoses of a healing abrasion. Everybody okay so far? Good. I'll take that as a yes. So here's another story. Yeah, this is a 75-year-old lady with a painful right eye, hazy vision, and she has nausea. What do you think? And again, not enough to clinch it because not enough bits of information. Yeah, very good. It could be acute glaucoma. It's not likely to be just glaucoma, because you have to separate glaucoma into open angle and closed angle. So 80% of UK glaucoma, so raised pressure problems, is open angle, which is just a chronic condition. The patient is just unaware, like essential hypertension, they're unaware of their blood pressure that's being a bit too high. The patient's unaware of their intraocular pressure being too high, and they get chronic optic neuropathy as a result. With acute glaucoma, it's a bit more like a hypertensive crisis. You know, suddenly the intraocular pressure goes up because there's just not enough space for the fluid to get out, particularly in an elderly patient when their lens has become bigger and the angle closes, and then the pressure screams up very rapidly and it gives dreadful pain. And it can also just cause nausea and vomiting and confusion and confusional state. And there are many stories of patients who've been admitted into hospitals with abdominal pain and confusion, and all sorts of investigations for infection and things are done for an elderly patient, but actually the underlying problem is acute angle closure. I'll show you the picture. Ooh, hang on, sorry. There we are. This comes from Iowa. Iowa publish their eye rounds on the internet, and they're really brilliant in things to look at. But here we go. You can see straight away, elderly patient. The key thing is this. Have a look at this eye. And if you have a look in the pupil, you can see that this patient has not had cataract surgery because there's a haziness in their pupil there. It is very, very, very rare to get acute angle closure glaucoma in a patient who's had a cataract operation, because when you take the lens out, the new intraocular lens that you put in is very slim, and the iris drops right back and the iridocorneal angle opens up very considerably. And in fact, doing cataract surgery is a very good treatment for angle closure, and it's actually one of the recommended ones now. So it's very unlikely that people will get angle closure glaucoma if they've had a cataract operation. So when we look at this one, the pathological side, you can see the redness or the injection based around the base of the iris. The cornea is all hazy. The pupil is mid-dilated, and there's a natural human lens in there. The crystalline lens is sitting there. So that is very indicative of angle closure. Anybody think of anything else it might be? Because angle closure glaucoma can either be primary or secondary, i.e. it can be a problem in itself because of the structure and the shape of the eye, or it can be angle closure or acute glaucoma can be secondary to something else. So if that's angle closure, we put that in. it could be related to a vein occlusion. So why on earth is that? So that we would often sometimes see patients come to the casualty with a pressure of 50. When you look at their eye in a bit more detail, they've got a little bit of blood vessel growth on their iris. They've got some rubeosis sitting there, and it's the rubeosis and the new vessels that are forming because the eye has become very ischemic because of the central retinal vein occlusion, and that's stimulated the neovascular process. Sometimes patients lose the vision in one eye or get blurry vision. They don't really notice it very much because they use both eyes all the time. And we get patients presenting with very high pressure. It looks exactly like angle closure, but it's actually not. It's actually the underlying problem is a vein occlusion. And on the slit lamp, and certainly when you've dropped the pressure and you can see the iris, you'll see little wiggly red vessels all the way around there. So that's the other differential diagnosis. Now I've put here, you've already read it, herpes keratitis. So what on earth do I mean by that? I don't mean herpes simplex, because the elderly age group don't get herpes simplex, they get herpes zoster. And if you have herpes zoster ophthalmicus, I'm sure you've seen that many times, the patient gets a few crusts and they feel terrible, and it begins to get better, but then they can get an inflammatory condition in their eye, a herpetic uveitis, and that can then actually cause very significant inflammation in the trabecular meshwork, and that then can result in the pressure screaming up. And I remember seeing a lady in the clinic a few months ago who came in, and she put her fringe over her eye because it was hurting her so much, and the light was hurting her eye, and I had a look and I thought, oh my goodness, her cornea is really very hazy. I thought, well, she's probably got a vein occlusion, was my initial thought. And had a look, and there was no rubeosis, and her pupil was actually reacting to the light. And as I pushed her fringe a little bit further back, she had a few crusty lesions in the healing phase, and so she had a high pressure because of her herpes zoster related uveitis. So those are the other two differentials to think of in that situation, which is quite interesting to know. There's various things to think through for this, and these patients feel terribly ill, and they get better quickly once the pressure drops down with the appropriate treatment. Hang on, oh, I think this might be the last. So here, oh yeah, this is the. Oh, there's a couple more. I think we're okay for time, aren't we? So here's a red right eye for 3 days, and it's painful and it's aching, and the patient wore their contact lens overnight, and here's the picture. What do you think of that? So when I see this, young people tend to wear contact lenses and could just be a little bit of conjunctivitis because they've worn their contact lens overnight. It could be a bit of a broken contact lens, because I've seen that where the lens actually breaks a bit and they leave it behind and they've got a foreign body. But the other thing you have to think of very carefully is whether this patient has, oh, here we go. Could be herpes keratitis. Yeah, absolutely. It could be, because young people get herpes keratitis. That's not particularly triggered off by wearing contact lenses, but it could be that. But the key thing to think about is sorry, pointers all over the place, whether this is a microbial keratitis, because the thing that stops the bacteria from getting into your cornea is the corneal epithelium, and that's the barrier. Once you get into the corneal stroma is basically type 1 collagen, glycosaminoglycans at 35 degrees C with no blood vessels. It is an agar plate, basically. So as soon as you've got a breach in the epithelium, bacteria can get in. And in contact lens wearers, the commonest one is Pseudomonas aeruginosa, which is a very aggressive gram-negative organism. And that, once it embeds itself in the cornea through a breach in the epithelium, it can perforate the cornea in 24 or 48 hours. Staphylococci can do something very similar. And the other one that people get, which is a bit more slow to kick off, is which is also desperately serious, is acanthamoeba keratitis. And the risk factor for that is using tap water to wash the contact lenses with. But then I put this picture in because if I put in and search for a picture of microbial keratitis, it's too obvious. You can see it. There's a great big white blob on the cornea. But look at this picture here. you can't see the whole of this patient's cornea. It's covered up by the upper lid a little bit. And quite often in the eye casualty, we will see a patient who looks like this, and in the naked eye, it doesn't look like there's any big problem at all. When you look on the slit lamp, you can see a tiny little white dot, and they're just brewing the beginning of their microbial keratitis. So always think in the presence of a contact lens that they may be getting corneal infection, because that would be very serious, particularly if it's painful and aching. I want to tell you something else as well, which is that if you have somebody who wears the contact lenses, the microbial environment of their ocular surface is very different to how it should be because of the foreign body that's there. And chloramphenicol is not at all helpful in Pseudomonas. It doesn't stop pseudomodal infection in any way. So giving somebody chloramphenicol drops or ointment when they've got a contact lens related abrasion on the surface of the eye, you might as well not give them anything, because it's not going to have any effect if they've got a Pseudomonas around. So if somebody has a small abrasion from their contact lens, then we would always give them a quinolone like ofloxacin or ciprofloxacin drops. So because that will have quite good activity against Pseudomonas if it's there. So just to protect the patient from getting a big corneal ulcer, which is difficult to treat and can leave them with a central scar and reduced vision, it's sensible just to be wary of contact lens wearing. To just worry about a contact lens wearers, because they might have a little bit of Pseudomonas, and you've got to think of that. So that's why I put that one in, because this is probably not an uncommon way for a patient to present to you. I think I've got that written here. Yeah, it could be a foreign body, could be microbial keratitis, and it could be herpes keratitis as a secondary thing as well. Quite often, if it's herpes keratitis, people have had it before, so they know all about it, and they tell you, and then you can be fairly confident that that's that. I think we've got the last one, which you'll be pleased to hear. 43-year-old, slightly red eye, lower part of vision is blurred. I'm really mean, aren't I, with the information? And if you can hear running water, it's because there's a broken tap behind me, because this is the NHS, and it's been dribbling like that for weeks. So what do you think? I think you need a bit more information than that, don't you? So I'm going to give you a bit of information by showing you the picture. Now, what do you think? You have to look carefully at this. So if you look carefully at this, there's a nice bit of a story here, because you can see that the eye is a little bit red, but what else you can see on the surface is, can you see that little ring there, that little line there, all the way around? So this patient, fairly young by the looks of the lid skin here at 43, nice deep anterior chamber, that's very important. Contact lens. So you think to yourself, what is this eye telling me? So contact lens wearers, they wear contact lenses because they are short-sighted. So this patient is myopic, is what the contact lens is telling you by and large. Very few hypermetropic people really wear contact lenses. So there's the contact lens in the myopic patient. The eye might be slightly red because they're wearing the contact lens, and that doesn't look terribly aggressive redness, so that's nothing too dramatic. What about if the lower part of their visual field is blurred? What does that mean? In the presence of short sight, it could mean that, well, certainly if your lower part of your vision is blurry, it means the top part of your retina or the top part of your optic nerve has stopped working. And the commonest thing that's going to affect a youngish, short-sighted patient at the top part of their retina is a retinal detachment. And if you ask further bits, of history, have you had any flashes of light? Have you had any floating spots? They might say yes. They've had a few flickers, and it's a little bit blurry, and the blur is slowly creeping upwards. Those are all warning signs of a detached retina. In a young patient like this, again, not particularly associated with a myopia, but they could also get a vein occlusion in the top half of their retina, or an arterial occlusion in the top half of the retina that would give them the lower half of the vision is blurred. And if they're very unlucky, they could get an optic neuropathy that might do the same thing. So the 43-year-old with a slightly red eye and the lower part of the visual field is blurred has got a serious problem. And the contact lens is telling you it's possibly a detached retina. The other thing is when the retina becomes detached, it becomes a little bit ischemic and you get some inflammatory response to that. So it's not uncommon for us to see a little bit of mild anterior chamber inflammation in a patient who has a detachment beginning. So I wanted to show you that because the clues are there, particularly just this little thing telling you that. I think I've got that written there. So it could be a vein occlusion artery, it would most likely a detached retina. So just to summarize, then, I think with every consultation, you use your Bayesian analysis. And each time you ask a question, you just think to yourself, what's this telling me? What is this eye telling me? And where do I go next on my next search for what's going on? Because that leads to a good assessment overall. And it doesn't matter if you don't get to the diagnosis, particularly what you will get to fairly quickly is whether you're comfortable to manage that patient because they've clearly got an abrasion or a small foreign body that you've removed or a bit of viral conjunctivitis or something, or whether you need a little bit of help by calling the local eye casualty or sending the patient in to the ophthalmologists. And you should well be able, with your assessment, to be able to separate those three fairly easily. Yes, is the answer. Should we prescribe ciprofloxacin drops first lines for conjunctivitis if the patient is a contact lens wearer? Yeah, I would, yeah. Absolutely. Because you just have to be slightly wary of the pseudomonal infection because it can kick off within a day. And what I do is I tell the patient, use these 4 times a day for 5 days. Don't wear your contact lenses. And if it gets better, that's fine. You can start using the contact lenses again. But if it doesn't get better, then they need to go back or they need to go to the eye casualty. And certainly if it gets worse. And the other thing you can ask a contact lens wearer to do, most of the time people dispose of their lenses these days, but actually asking them to keep the offending contact lens and to keep the container, if it's a monthly one, keep the container, because sometimes if we struggle with the microbiology, we send the lens off and we send the container off to see what we can culture from that. That would be the best advice.
That's lovely. Thank you, Nigel, for the slides. There were so many great case studies in there. I think it sounds like it's a good time to switch to questions. So if anybody apart from Richard wanted to throw anything into the chat or just raise it verbally, then you've got 10 or 15 minutes to...
Yeah, I wanted to give a bit of time at the end. You don't want me harping on for too long.
No, it was a really great. Mira, go for it.
Yeah, thank you very much for the talk. It was really good, actually. So I wanted just to ask, you mentioned about the acute glaucoma.
Yeah.
And if you said sometimes patients can only present with confusion, nausea, vomiting. Does that mean that you don't always get red eye with
yeah, so what actually would happen with acute glaucoma is it goes through various different phases. So it will kick off often at some point during the day, and the eye will go red, the cornea will go hazy, but the person can be so full of pain, they don't want to go out. So they take some paracetamol, they go to bed, they think it's going to get better. And sometimes they just sit at home for 2 or 3 days. After it's been present for a couple of days, the initial redness will fade away. And the cornea, sometimes the pressure will also start to come down. It might shoot up to 50 or 60 millimeters of mercury. The reason why the cornea goes cloudy is that the endothelial cells on the back surface of the cornea, their one role in life is to pump the water out of the cornea back into the anterior chamber to keep the cornea dehydrated and clear. And they can do that until the intraocular pressure reaches 55 millimeters of mercury, and then the forward push is just too much and they can't cope, and then the fluid gets into the cornea and the cornea goes hazy. But as the angle closure begins to resolve, because what will happen is that the ciliary body itself the blood vessels get squeezed so much by the high pressure that it becomes ischemic, and it stops producing aqueous, then the pressure starts to drop a little bit. The angle can still be closed, but if the pressure drops to below 50, goes down to 45 or something, or maybe 40, then the endothelial cells will start pumping the fluid out again, so the cornea can become clearer. So you can definitely get people who are still in this confusional state, who've got angle closure, but the signs are fading away. And the other thing is, of course, is that sometimes with the nausea, and if there's been vomiting, they get a confusion because the electrolytes go out of skew as well. So they can present late, funnily enough.
Okay.
Does that make sense?
Yeah, that did. Thank you.
Any more questions? You can ask them by, like Mira did, by raising a hand and turning your audio on, or you can drop them in the chat. If you can't see the chat, it's in the black bar at the bottom of the screen, and it just says chat with the chat box. And just while we kind of canvass for any final questions, Nigel, are there any kind of clinical guidelines that have come out this year that you think GPs should be ahead of?
Not that I can think of particularly. Oh, thank you, Sally. I decided not to talk too much about all the retinal stuff in detail. That's my subspecialty, because there's an awful lot of things with intravitreal injections that are always new and changing. Because the intravitreal injection service for patients with wet macular degeneration and diabetic macular edema and vein occlusions across the nation is struggling a little bit. And there's a constantly changing armamentarium of treatments that we give. But the key thing for the intravitreal injection service is actually getting the patient their appointment. And sometimes they might come to the GP and say, look, I'm supposed to have an injection every 8 weeks and I just can't get the appointment. And I think then just a little bit of shouting and helping the patient get through to the eye services is a good idea.
That's great.
We haven't had any new dramatic guidance come out about anything particularly recently.
That's super. All right, well, I think we can give people back the last 5 minutes of the hour.
We can, yes.
Well, I think everybody would like to join me in thanking you, Nigel. For your
great pleasure. Yeah, I've enjoyed it. Thank you so much for listening as well. Yeah, okay. Have good afternoons, everybody.
Thanks, everyone.
Okay, bye-bye.